Hello, my name is Eddie Jones. I am an associate professor of surgery at the University of Colorado and a director of surgical endoscopy at the Rocky Mountain Regional VA. I'm talking today about operating room fires. I have nothing to disclose. These are the objectives we'll review today. We'll review what exactly is an operating room fire, and then go into the incidence of OR fires. We'll then touch on what each of us can do to help prevent them. And finally, what happens if an OR fire starts in my OR? So what exactly is a fire? We all have in our mind this idea of a campfire, I think, with bright yellow flames reaching up into the sky and everyone yelling fire and running away. Unfortunately, an alcohol-based fire, and most of the fires in the OR are going to be fueled by an alcohol-based prep, often has a nice blue flame, very pretty. Unfortunately, when surrounded by sterile blue towels, these can be very hard to identify and can rapidly get out of control. In addition to that, if you look at the technical definitions of what an OR fire is, it also includes, as you can see on the second bullet point, a smoldering condition without flame is still classified as a fire. And this is taken directly from the Joint Commission requirements as to the definition of an OR fire, and thus, unfortunately, can also be reported as an OR fire. This comes into play, especially with laparoscopy, where the fiber optic light cord, when left in place for a short period of time, can result in burns through our drapes, in our blue towels and green towels and what have you. This would also be classified as an OR fire, even though it may not have extended beyond that single site nor harmed the patient. So how common are OR fires? And this is older data, and it did not include the quote-unquote fires from your fiber optic light cords. This was 2009 out of Pennsylvania. And they identify 500 to 65 events per year in the US. This results in 2 to 3 deaths per year. This sounds like small numbers. It's probably significantly underreported because there's no national database. So what's the big deal? Well, there are two parts to that question. Number one, Doug Overby and the team out of University of Colorado did a nice database review of the FDA's manufacturer and user device experience database, looking specifically at energy device-related fires, and found a significantly increasing trend in recent times. 2015, 2016, there were significant jumps in the incidence of fires in the OR. In addition to that, it only takes one bad case to not only result in patient harm, but also result in likely harm to the hospital and the entire hospital system. Here's an example of a very well publicized case from the mid-2000s where a young woman was undergoing removal of a mole under MAC with an energy device, and a very brief OR fire was ignited and resulted in significant disfigurement and further damage, as I mentioned, not only to the patient, but also to the hospital system as they recovered from this well-publicized incident. So let's focus on how we prevent these OR fires. As you may know, fires are built of three things: fuel, heat, and an oxidizer. The most common oxidizers are oxygen in 90% of cases, but can also be nitrous oxide. Fuel is most commonly alcohol-based skin preps, but can also be drapes and gowns and even the patient's own hair and tissue. Heat most commonly is our electrosurgical units, also known as DeBovi, but lasers and fiber optic lights can also serve as a heat source. So let's start with the oxidizer. Operating room fires in a relatively recent closed claim analysis identified that 85% occurred in the head and neck or upper chest, 81% under monitored anesthesia care. Almost all of these included the presence of supplemental oxygen. Now, these are considered an open oxygen system, such as a nasal cannula or a mask, where additional oxygen is given to the patient. And in low flow situations, which we've defined as less than or equal to 4 liters per minute, we can increase the local oxygen concentration by about 5%. If you turn it up to 5 liters or more, all of a sudden we can increase our local oxygen concentrations 35% up to 50% more. And keep in mind, we're starting at room air, which is already 21% oxygen. If you do some kind of draping or tenting of the drapes, you can increase your oxygen content significantly higher than that with just a simple nasal cannula or a mask. And what I want to show you is that when your oxygen content increases beyond about 30%, once you hit that 5+ liter mark, things that are not usually flammable, can't usually catch on fire, all of a sudden become flammable. Here's a nice study by Bill Culp out of Texas, looking at some standard devices that, as you can see there, they have class 1 normal flammability. They're really not flammable except in special situations, such as utility drape or surgical gown. And here is what he looked at. Let's start with the utility drape and surgical gown. At 21% room air oxygen, they did not ignite, could not light them on fire. You dial up the oxygen content to here in the study about 50%, and they ignite in just 1/4 of a second, 2/10 of a second, 4/10 of a second. If you want to look at burn time, the operating room towel, if you put a flame to it, will burn in about 22 seconds, and the surgical drape in about 15. If you turn up that oxygen content, all of a sudden it drops by more than 1/3. 7 seconds, and that operating room towel is gone. Surgical drape is up in less than 5 seconds. If you look at it on a nice curve, I think this emphasizes it well. As you dial up the oxygen content, the time it takes for normally non-flammable objects to burn rapidly declines. And this is why I start with the oxidizer, because I think it is the single most important item when considering OR fires, is we need to manage the oxidizer. You need to consider using a closed oxygen system in high-risk situations. If you're going to be operating on the face, right near the mouth or the nose, I would consider using an endotracheal tube. Keep in mind, this isn't 100% protective, but it's a lot more protective than having a mask with additional oxygen right next to where you're working. We need to avoid oxygen content greater than 30% where at all possible, and avoid creating pockets of oxygen with our drapes. Keep in mind that your surgical scalpel is not flammable. If you don't add an energy device, you can use as much additional oxygen as you like. Let's move on to heat sources. Surgical energy is about 90% of the cases out there, and that includes your standard handheld Bovie. Lasers and light cords are also common sources. I think the most important point to recognize is we need to select the appropriate wrist device for the procedure we're performing. If you're working in the airway and creating a tracheostomy, we don't want to be cutting into the trachea with an energy device while the oxygen is elevated. And if we're doing this procedure and we get into significant bleeding, utilizing an energy device doesn't make a whole lot of sense. Let's use our good surgical technique, and in this high-risk situation, suture ligate that vessel that's bleeding. We want to continue to focus on reducing our risk for these OR fires. And as I already mentioned, we began with the oxidizer. We need to limit the amount of supplemental oxygen we use, or use it in a more controlled fashion. In addition, we need to pay attention to our electrosurgical device. We need to use the Bovie where appropriate, and use other surgical techniques when the risk is high. So let's move on and finish out with fuel. This is a study that Doug Overby and I published a few years ago, looking at alcohol-based preps and non-alcohol-based preps. And what we found is that when you use a non-alcohol-based prep, such as plain chlorhexidine or plain iodine, you cannot light a fire. However, when you add alcohol to those and use ChlorPrep, for example, or DuraPrep, some of the most common ones out there, you can light a fire in 1 in 5 cases. In just waiting 3 minutes per the manufacturer guidelines for it to dry, you can still light a fire in 1 in 10 cases in our study. And these aren't just little flash flames that we were encountering. If you look at panel C down at your bottom left, you can see a very large fire that would rapidly get out of control and cause significant injury to the patient and maybe even the OR team. We look to identify what other characteristics beyond the presence of alcohol itself we could affect in order to reduce the risk of OR fire. And what we found was pooling. If you allow the prep to pool, for example, in the umbilicus when you're doing an abdominal procedure, it is nearly impossible to not light a fire. As you can see on the top line there, 95% of the times, 19 out of 10 out of 20 cases that we tried, we could light a fire. Even after waiting 3 minutes, when there was a pool present, we could light a fire 75% of the time. This is the #1 highest risk with an alcohol-based prep. Do not start your case when there's a pool of prep. And it's not just in the umbilicus. It can be along the drapes, along the side of the patient, or it flowed underneath onto the towels and saturated those towels. So we have to be very careful and not drape the patient until the prep is dry and there are no pools present. And that's nicely summarized here. Fire risk assessments have come out, and I think they're very important. They're used in a lot of different institutions, and they help draw attention to the idea that there is a high risk or low risk of fire. I think these are particularly important in places that do a lot of MAC, monitored anesthesia care cases with supplemental oxygen. This helps everyone identify that the patient and the situation is high risk for fire, and we need to take additional steps in order to protect our patient and our team from OR fires. So we've worked our way through the first 3 topics here, defining what fires are and how often they happen. So let's look at, what do I do if a fire starts in my OR? It is rarely this exciting. Oftentimes it's a small blue flame and we need to identify it immediately. But what are the appropriate steps? #1, we need to stop the flow of airway gases. If the patient is intubated, we need to remove that endotracheal tube, especially when there's additional oxygen flowing in. If it is an airway fire, you need to remove that endotracheal tube and pour saline in the airway. But step #1 is to stop the flow of airway gases and, in an intubated case, disconnect the breathing circuit. Oftentimes, these steps will happen concurrently. So while anesthesia is stopping the flow of airway gases, we need to remove all of the burned and burning material immediately. We can extinguish a fire on that burning material and on the patient if it's still present or as we are removing it. And then finally, restore breathing care for the patient. This is pretty simple and straightforward, but what I want to continue to emphasize is step #1 is stop the flow of gases. Get the extra oxygen out of there. Otherwise, things that are not normally flammable will continue to be flammable. So one more time, let's review. Oxidizer. We need to avoid local concentration of oxygen greater than 30%. Take special care when you're using monitored anesthesia care or mask to provide supplemental oxygen to our patients when you're doing your procedure. In those high-risk situations, if you can avoid a spark by not using a bovie and using your scalpel instead, then there should not be a risk for an OR fire. And finally, if at all possible, it is smart to avoid an alcohol-based prep in the appropriate situation. And if you are using an alcohol-based prep, make sure that you do not drape prior to that 3-minute time window has expired, and you have taken care to ensure that there are no pools of the solution. Here are my references. Thank you for your time and attention.